Welcome back to the Deep Dive. Today we are plunging into the absolute depths of how our bodies handle fluid, how things go wrong to cause swelling, what we call edema, and how understanding those really intricate mechanisms is key to figuring out what's actually going on underneath.
Yeah, it's fundamental.
We're going to get into the weeds on this, really aiming for a level of understanding that approaches true mastery, kind of like the elite professionals who grapple with these concepts day in, day out.
Exactly.
We'll also touch on some other vital physical signs, clues to underlying conditions, things like clubbing of the fingers and toes, and the sounds of heart murmurs.
That's right. And our guide for this deep dive is the source material you shared with us. These are excerpts from a medical text. We're going to lean pretty heavily on Chapter 41.
Okay.
It provides an incredibly structured and frankly detailed exploration of edema. We'll be delving into its fundamental mechanisms, the complex systemic forces that regulate it, and its many clinical presentations. And we'll also fold in the information on clubbing, that's also in Chapter 41, and the sort of foundational overview of heart murmurs from the Chapter 42 excerpts.
So think of this as like taking that textbook knowledge and really trying to bring it to life.
Yeah.
We're not just reading facts here. We're exploring the connections, the why behind the what. Our mission is to unpack these complex concepts so thoroughly that hopefully you feel genuinely well-informed, ready to tackle this topic with, confidence. Okay, let's dive in.
All right. Let's start with the very fundamentals of edema, right down at the cellular and tissue level, just as the source text does. At its absolute core, edema is defined as an excess accumulation of fluid.
Where?
In the extracellular spaces of the body.
Okay, extracellular. And to really appreciate where that excess fluid is pooling, we need to understand where water normally lives in our bodies. The text breaks this down pretty clearly.
It does.
Roughly 2/3 of our total body water is actually held inside our cells. That's the intercellular compartment.
Right. Leaving the remaining 1/3 outside the cells, that's the extracellular space.
Okay.
And that extracellular fluid isn't all uniform. It's further divided. About 1/4 of that extracellular fluid is in the plasma.
The fluid part of the blood.
Exactly, the fluid component of our blood circulating within our blood vessels.
And the really crucial part for understanding edema, the rest of that extracellular fluid, so about 3/4 of it, is the interstitial fluid.
That's the key.
This is the fluid that surrounds the cells in our tissues, filling the spaces between them.
Precisely. So when we talk about edema, we are specifically pinpointing an excess of fluid accumulating in that interstitial fluid space.
Right.
It's the tissues themselves getting kind of waterlogged. It's not necessarily the blood vessels filling up more or the cells swelling. It's the space between the cells.
Got it. So how does fluid normally move between the plasma inside the vessels and that interstitial space outside? The source describes this exchange at the microvascular level right across the capillary walls.
Yeah, and this movement is driven by a balance of forces. They're often referred to in a simplified way as Starling forces.
Okay.
The source highlights the movement from plasma into the interstitium first. This is primarily driven by the capillary hydrostatic pressure.
Hydrostatic pressure. Think of that like the water pressure inside the capillary pushing outward.
Exactly, like water pressure in a garden hose pushing outwards against the walls.
Okay.
And that pushing pressure is highest at the arterial end of the capillary, right where blood enters from the arterial under higher pressure.
Makes sense.
Then, as the blood flows through the capillary towards the venular end, that hydrostatic pressure naturally falls off. It decreases.
Okay.
The other force mentioned that promotes fluid movement out is the colloid oncotic pressure in the interstitial fluid. But normally this is pretty low because there aren't that many proteins hanging around outside the vessel to pull water out.
So fluid gets pushed out, especially at the beginning, the arterial end. What about getting fluid back in or draining it away?
Right. While some fluid might technically be drawn back into the capillaries at the venular end, where that hydrostatic pressure is lower, and the plasma oncotic pressure.
That's the pulling pressure from proteins like albumin inside the capillary.
Exactly. That pulling pressure is relatively higher there. But the source really emphasizes that the return of fluid from the interstitial space back into the vascular system happens largely through the lymphatic system.
Ah, the lymphatics.
Yeah, these are like a parallel set of vessels. They act like a drainage system, picking up the excess interstitial fluid, including any proteins that might have leaked out.
Okay.
And they return this lymph fluid eventually back to the bloodstream.
So the lymphatics are kind of like the crucial overflow drainage system for the tissues.
That's a great way to put it. And, in the normal state, these movements are beautifully balanced.
Right.
The amount of fluid pushing out, the amount potentially pulled back in, and the amount drained away by the lymphatics, it's all in equilibrium.
And this keeps the volume steady, both in the blood vessels, the intravascular compartment, and in that interstitial space.
Exactly. Constant volume.
But when that balance gets disrupted, that's when we get edema.
That's it.
The source lists 5 key conditions or mechanisms that cause a net movement of fluid from inside the vessels, the intravascular space, out into the interstitial space, leading to that buildup.
Okay, let's tick through those. First, an increase in intracapillary hydrostatic pressure.
So if that pushing pressure inside the capillaries goes up a lot?
Yep. More fluid is forced out than can be returned or drained away by the lymphatics. Simple physics, really.
Okay, mechanism 1, too much push out. Mechanism number 2.
Inadequate lymphatic drainage. If that lymphatic system, the drainage network, is blocked or damaged, it just can't pick up the fluid that naturally leaks out, even under normal pressure. So the fluid backs up and builds up in the interstitium.
Blocked grains, got it. Third mechanism.
Reductions in the oncotic pressure in the plasma.
Okay, this is about the protein levels inside the blood vessels.
Exactly. If you don't have enough protein, particularly the main one, albumin, circulating in the blood, then that pulling force that helps keep fluid inside the blood vessels is weakened.
Right.
And this allows more fluid than usual to leak out into the interstitial space.
Okay, so not enough pull holding fluid in. Mechanism 4.
Damage to the capillary endothelial barrier. This is when the walls of the capillaries themselves become more permeable, more leaky.
Like holes developing in the hose?
Sort of, yeah. This allows not just extra fluid, but also proteins to escape more easily out into the interstitial space.
So the barrier itself fails. And finally, mechanism 5.
Increases in the oncotic pressure in the interstitial space.
Wait, oncotic pressure outside the vessel? How does that happen?
Well, if protein leaks out into the interstitium, which happens with capillary damage, like in mechanism 4, or if the lymphatics aren't clearing it, like in mechanism 2, that protein outside the vessel starts exerting its own pulling force. It pulls fluid out of the capillaries and holds it there in the interstitial space, contributing to the edema.
Wow. Okay, so what's fascinating here is how these 5 points all trace back directly to disrupting those fundamental forces we talked about. Hydrostatic pressure, oncotic pressure, the capillary wall integrity, and lymphatic drainage.
Exact.
And it really boils down to either too much push out, not enough pull in, a leaky barrier letting things escape, or blocked drainage preventing removal.
You got it. And any single one of these can theoretically cause edema, but as you hinted, often in complex conditions, multiple mechanisms are actually at play simultaneously.
Right. Which leads us to think, okay, those are the local mechanisms at the capillary level.
Yeah.
But what causes widespread generalized edema? That often involves bigger systemic issues, right?
Absolutely. And the source introduces a really crucial concept for understanding many forms of generalized edema, the idea of reduced effective arterial volume.
Okay, this sounds a bit paradoxical. How can you have too much fluid in the tissues, the edema, but somehow reduced volume in the arteries?
That's the million-dollar question, isn't it? It seems counterintuitive. But the text explains that effective arterial blood volume isn't just about the total liters of blood in your body.
Okay.
It's more of a functional concept. It represents how well the arterial side of your circulation is filled and whether it's effectively perfusing your tissues and organs. It's about having enough pressure and flow on the arterial side to keep everything running properly.
Okay, so even if your total body fluid is high, like in edema, if the arterial system isn't being effectively filled or pressurized, the body kind of perceives this as a problem, like it's low on volume.
Precisely. The body's sensors are mainly monitoring that arterial side, and the source lists several ways this arterial underfilling can happen, leading to this perception of hypovolemia, even when there's excess total body water.
Like what?
Well, it can be due to a reduction in cardiac output, if the heart isn't pumping enough blood forward.
The arterial tree doesn't fill properly.
Right. Or it could be a reduction in systemic vascular resistance. If the blood vessels throughout the body dilate too much, the pressure drops, and again, you get poor arterial filling and perfusion.
Or pooling of blood, you mentioned that.
Yes, significant pooling of blood in certain areas, especially the large veins in the abdomen, the splanchnic circulation. This is a major factor in conditions like advanced cirrhosis.
So blood gets kind of trapped there.
Yeah, it gets sequestered there, not effectively returning to the heart to be pumped out into the arterial system. And finally, hypoalbuminemia.
Low blood protein.
Right. We already discussed how that reduces plasma oncotic pressure, allowing fluid to leak out of the vessels. This leakage directly reduces the effective circulating volume within the vessels.
So the body senses this arterial underfilling, this perceived low volume, and it thinks, emergency, need more volume.
Exactly. It kicks off a whole cascade of compensatory responses designed to try and restore that effective arterial volume back to normal.
By holding on to salt and water.
That's the primary strategy, yeah. The goal is to increase the total body fluid volume and hopefully refill that arterial tree. But as you can probably guess,
Holding on to more fluid when you already can't keep it in the vessels or the heart can't pump it just makes the edema worse.
that's the cruel irony. The compensatory response becomes part of the problem.
And the kidneys are absolutely central to this compensatory fluid-retaining response, aren't they?
Oh, absolutely critical. Diminished renal blood flow, which occurs when that effective arterial volume is reduced, is a key trigger. It signals the kidneys to start retaining sodium and water.
Right.
This is the body's main way of trying to correct the perceived volume deficit, but, as we said, it directly contributes to the formation or worsening of edema.
Which brings us to the real heavyweight champion, or maybe the main villain in this whole volume regulation story, the renin-angiotensin-aldosterone system, the RAAS.
Yes, the RAAS. Understanding the system is absolutely critical. The trigger for activating RAAS is precisely that diminished renal blood flow, often stemming directly from the reduced effective arterial volume we were just talking about.
Okay, so low flow to the kidneys kicks it off. Where exactly does it start?
It starts right in the kidneys themselves. There are specialized cells called juxtaglomerular cells.
Juxtaglomerular. Okay.
Yeah, they're located around the afferent arteriole. That's the small blood vessel leading into the filtering unit of the kidney, the glomerulus.
And these cells are the sensors.
They are. They sense the reduced blood flow and pressure coming into the glomerulus.
And their response is?
They translate that signal into increased release of an enzyme called renin.
Okay, so low kidney flow signals juxtaglomerular cells, which release renin. Got it. What's the next step in this chain reaction?
So renin is an enzyme, and it circulates in the blood looking for its substrate, a protein called angiotensinogen.
Angiotensinogen, made by the liver.
That's right, synthesized by the liver. Renin finds angiotensinogen and basically cleaves off a piece, creating a small peptide called angiotensin I.
Angiotensin I. Okay. Still not the main active player yet, I assume.
Correct. Angiotensin I is sort of an intermediate. It then needs to be converted into angiotensin II, or AII.
Okay.
And this conversion is primarily carried out by another enzyme called angiotensin converting enzyme, or ACE.
ACE. I've heard of ACE inhibitors.
Exactly. ACE is found in very high concentrations in the capillaries of the lungs, but it's also present elsewhere in the body. It converts AI to AII.
So angiotensin II, this is the main effector hormone of the RAAS cascade. What does it do? It sounds important.
It is incredibly important. Angiotensin II is a very, very potent vasoconstrictor.
It tightens blood vessels.
Yes, it causes blood vessels throughout the body to narrow, which helps to increase blood pressure and systemic vascular resistance. The body's trying to restore perfusion pressure to that underfilled arterial tree.
Okay.
But the source text highlights its particularly crucial effects right back in the kidneys.
Specifically on the efferent arterioles, the vessels leaving the glomerulus.
Exactly. This is a key point. By constricting the efferent arterioles, the exit vessel, even more than the efferent entrance vessel, AII does a couple of things. It helps maintain the filtration pressure inside the glomerulus, which is good for filtering waste. But it dramatically changes the fluid dynamics in the peritubular capillaries.
Peritubular. Those are the tiny vessels surrounding the kidney tubules where most of the reabsorption happens.
Correct. That's where the kidney decides what to keep and what to let go in the urine.
So how does constricting the efferent arteriole, the exit pipe from the filter, affect those downstream capillaries around the tubules?
Okay, think about it. If you squeeze the exit pipe, the pressure after that constriction in the peritubular capillaries actually goes down.
Ah, okay. Lower hydrostatic pressure pushing outwards from those capillaries.
Right. Less outward push. And at the same time, remember that fluid has just been filtered out in the glomerulus, leaving the blood going into these peritubular capillaries more concentrated with proteins. Right. So the source notes that this increases the caulate osmotic pressure, the pulling pressure inside these vessels.
So in the capillaries surrounding the tubules where reabsorption happens, you now have lower pushing pressure and higher pulling pressure.
Precisely. And the text makes it crystal clear. These combined effects, lower hydrostatic pushout, higher oncotic pull, significantly enhance the reabsorption of salt and water from the filtered fluid back into the bloodstream.
Wow.
This happens especially in the proximal tubule and also in the ascending limb of the loop of Henle. It's a direct, powerful mechanism by which AII forces the kidney to hang on to more salt and water.
That's quite a mechanism. And then there's the other major action of AII, right? Stimulating aldosterone.
Yes, that's the other arm. Angiotensin II circulates through the body and acts on the adrenal cortex, the outer layer of the adrenal gland sitting on top of the kidneys. Specifically, it stimulates a layer called the zona glomerulosa.
Okay.
And that stimulation causes the release of another hormone, aldosterone.
And aldosterone works further down the kidney tubule system, in the collecting tubule.
Correct. Aldosterone acts on cells in the collecting tubule. Its main job is to increase the activity and number of sodium channels and sodium pumps in those cells.
So it makes the collecting tubule suck back more sodium.
Exactly. It enhances sodium reabsorption. And wherever sodium goes, water tends to follow passively. Aldosterone also promotes the excretion of potassium here, which is why some drugs that block it are called potassium sparing.
Right.
So aldosterone is another crucial step in this RAAS cascade, powerfully promoting sodium and consequently water retention, which directly fuels edema formation.
And the source mentions the RAS operates both hormonally, with circulating AII and aldosterone, and also locally, like a paracrine system within the kidney.
Yes, that local action within the kidney can amplify its effects. The bottom line is clear. Activation of the RAS causes sodium and water retention and is a major contributor to edema formation in many, many conditions.
Which, of course, explains why blocking this system is so fundamental in treatment.
Absolutely, and the source highlights these therapeutic implications very clearly. Drugs that block the conversion of AI to AII, the ACE inhibitors you mentioned.
Like lisinopril and alloprol.
Exactly. Or drugs that directly block the angiotensin II receptors, the ARBs.
Zartan, valsartan.
Right. Both classes essentially break this chain. By reducing AI's effects, they reduce its direct action on tubular reabsorption and also reduce aldosterone release. The net effect is enhanced sodium and water excretion, which helps reduce many forms of edema.
And you can also target aldosterone more directly, or the channels it influences.
Yes, the text notes that too. Drugs that block aldosterone's action, like spironolactone or eplerenone, or drugs that block the specific epithelial sodium channels, ENOC, that aldosterone upregulates, like amiloride, these can also induce a moderate diuresis, meaning increased urine output, and help reduce edema in these fluid-overloaded states.
What's really fascinating here is how interrupting this specific, rather complex, multi-step hormonal pathway can have such a direct and honestly profound impact on the body's ability to get rid of excess fluid.
It really is. It's like overriding the body's own powerful but ultimately harmful in these situations, fluid retention signals.
Okay, so RAS is huge, but it's not the only hormonal player involved in volume regulation, right? The source also discusses arginine vasopressin, or AVP.
AVP, yes. Also commonly known as ADH, antidiuretic hormone.
Antidiuretic meaning it stops urination, essentially.
Very much, yeah. AVP is primarily released from the posterior pituitary gland in the brain. Its classic stimulus, the main trigger, is increased blood osmolarity.
Osmolarity, like how concentrated the blood is.
Exactly. When the body senses the blood is becoming too concentrated, usually because of dehydration, it releases AVP.
And AVP's job is specifically to hold on to water.
Precisely. It acts on specific receptors called V2 receptors located in the distal tubules and collecting ducts of the kidneys. Stimulating these receptors increases the insertion of water channels called aquaporins into the cell membranes,
allowing more water to be reabsorbed back into the body.
Yes, specifically the reabsorption of free water without necessarily needing salt to follow it. This increases the total amount of water in the body and helps dilute the blood back towards normal concentration.
Okay, that makes sense for dehydration. But how does this relate to edema, where the problem is usually too much water and salt?
This is where the concept of non-osmotic stimulus becomes absolutely key, as the source explains it. In many conditions that cause edema, like heart failure,
okay,
AVP levels are found to be high, not because the blood is concentrated, often it's actually diluted, but because the body perceives that reduced effective arterial volume we keep coming back to.
So the body's feeling of being underfilled overrides the signal from blood concentration.
Exactly. That underfilling signal, along with other related factors like reduced compliance or stretchiness of the left atrium, acts as a powerful non-osmotic stimulus for AVP release. The body is essentially tricked into thinking it's dehydrated from a volume perspective.
So it releases AVP to save water, even though there's already excess fluid backing up elsewhere in the system.
Precisely. And adding insult to injury, the text points out that patients in these edematous states often fail to suppress their AVP levels normally, even if their blood osmolarity drops lower than usual. This failure to turn off AVP further contributes to the inappropriate water retention and worsens the edema, sometimes leading to dangerously low sodium levels or hyponatremia.
Wow. It really is like the body's emergency volume saving system gets stuck in the on position, even when it's clearly hurting rather than helping the overall situation.
That's a very good analogy. The source also briefly mentions another peptide, endothelin-1.
Endothelin-1, released by the lining of blood vessels, the endothelial cells.
Yes, that's right. Endothelin-1 is an extremely potent vasoconstrictor peptide released by endothelial cells. Its concentration in the plasma is found to be elevated in patients with severe heart failure.
And like angiotensin II, it contributes to the problem.
It does. It contributes to renal vasoconstriction, which, as we've seen, enhances sodium retention. So in these sicker patients, it's another factor pushing towards edema formation.
Okay, so we have RAAS, AVP, endothelin-1, all promoting retention. What about the other side? Doesn't the body have systems to get rid of excess fluid? I'm thinking of the natriuretic peptides, ANP and BNP.
You're absolutely right. They are generally thought of as the counter-regulatory system, working against fluid retention. And they are released precisely in response to volume or pressure overload.
ANP comes from the atria.
Yes, atrial natriuretic peptide ANP is released by the heart's atria, the upper chambers, when they get stretched by increased blood volume.
And BNP, brain natriuretic peptide, but it's mainly from the heart too, right?
Correct. Despite the name, BNP is stored primarily in the heart's ventricles, the main pumping chambers. It's released especially when the pressure inside the ventricles rises during diastole, the filling phase.
Okay, so ANP and BNP are released when the heart feels overloaded. They bind to the natriuretic receptor A. What are their intended actions? What are they trying to do?
Well, the source lists two main beneficial actions that directly oppose those fluid-retaining systems we just discussed. First, they promote the excretion of sodium and water by the kidneys. They do this in several ways: by increasing the glomerular filtration rate, pushing more fluid through the filter, by inhibiting sodium reabsorption in the proximal tubule, and, very importantly, by inhibiting the release of both renin and aldosterone, directly counteracting the RAAS.
Okay, so they make you pee out salt and water. What else?
They also affect blood vessels. They cause dilation of both arterioles and venules.
So they relax blood vessels.
Yes. They achieve this by antagonizing or blocking the vasoconstricting actions of angiotensin II AVP and also sympathetic nervous system stimulation. So they try to lower pressure and reduce the workload on the heart.
Okay, so if they promote salt and water excretion and dilate vessels, they sound like the body's perfect natural defense against edema.
They absolutely are. And indeed, their circulating levels are elevated in conditions like heart failure and cirrhosis with ascites, where you have significant edema. That's why BNP measurement is a useful diagnostic test for heart failure.
But there's a but, isn't there? If they're elevated, why is there still edema?
Exactly. Here's the paradox the source points out. Despite being elevated, often very significantly, ANP and BNP are simply not sufficiently potent to prevent edema formation in these severe disease states.
So they're trying their best, fighting the good fight, but they're just overpowered by the retaining forces.
That seems to be the case. They're overwhelmed. And adding another layer of complexity, the text notes that in these edematous states, there might even be increased resistance to the actions of these natriuretic peptides. The receptors might become less sensitive, or the peptides might be broken down faster,
making them even less effective.
Right. This really raises an important question, doesn't it? Why does the body's incredibly powerful fluid-retaining response, triggered by that perceived arterial underfilling, consistently seem to overwhelm its equally present but apparently weaker fluid-excreting system in these diseases?
Yeah.
It perhaps speaks to the hierarchy of the body's survival instincts. Maintaining perfusion pressure might be prioritized above all else, even if the long-term consequence is damaging fluid overload.
Fascinating. Finally, the source briefly mentions the sympathetic nervous system, the SNS,
Yeah.
also playing a role.
Yes, the fight or flight system. Adrenergic stimulation from the SNS also contributes to edema formation.
Oh.
It causes renal vasoconstriction, similar to AII and endothelin-1, reducing blood flow to the kidneys. And it also directly enhances sodium and fluid transport or reabsorption by the proximal tubule epithelium. So it's yet another system pushing for fluid retention when the body senses that arterial underfilling or stress.
It truly is a complex interplay of signals, isn't it? Reduced effective arterial volume seems to be the central trigger, setting off RAAS, AVP, endothelin-1, and SNS activation, all forcefully pushing for salt and water retention and, unfortunately, often overwhelming the counterbalancing natriuretic peptide system.
That deep dive into the neurohumoral mechanisms is absolutely crucial for understanding the causes of edema, which logically is the next step in the source's structure. So, okay, how does all this complex physiology actually manifest clinically? How do we recognize edema when we see it?
Well, the source notes, interestingly, that you can actually gain quite a bit of fluid before it becomes visually obvious. A weight gain of several kilograms, often 5 kilograms, which is about 11 pounds, or even more, usually precedes the overt, visible manifestations of generalized edema.
Wow, that's a lot of hidden fluid.
It is. And when it is obvious and widespread, affecting the whole body, the term used is anasarca, gross generalized edema.
Anasarca, okay.
The text also lists sites that's fluid accumulation in the peritoneal cavity, the abdomen and hydrothorax, which is fluid in the pleural cavities around the lungs as special forms of edema. Ascites is apparently discussed more in Chapter 50.
Right.
But the classic physical sign most people recognize is pitting edema.
Yes, pitting edema. This is how edema is typically recognized clinically. You press gently with a finger on the swollen area, usually over a bony prominence like the shin. And if edema is present, the pressure displaces the interstitial fluid, leaving an indentation or a pit in the skin. This pit persists for a variable amount of time after you remove your finger.
Okay, but the source says there are more subtle signs, too, before it gets that obvious.
Definitely. The text mentions things like the rim of a stethoscope bell, leaving an indentation on the chest wall after listening to the lungs or heart. Or a ring on a finger suddenly feeling much tighter than usual. And a very common complaint is difficulty putting on shoes, particularly noticeable in the evening.
Ah, that evening shoe tightness. Classic sign of dependent edema, isn't it? Fluid pooling in the lower parts of the body due to gravity as the day goes on.
Exactly. Another sign mentioned is puffiness of the face, especially around the eyes, in the periorbital areas.
Why there specifically?
Because the tissue there is relatively lax, looser, making fluid accumulation more readily apparent. And the text notes this facial puffiness is often most pronounced in the morning.
Because lying flat overnight lets the fluid redistribute upwards to the face.
Precisely. Gravity isn't pulling it all down to the ankles when you're lying down.
Okay, so we know what it looks like, from subtle signs to obvious pitting and anasarca. Now, the source simplifies the differential diagnosis for generalized edema quite nicely. It states that the vast majority of patients with generalized swelling have it because of one of 4 main categories of problems: cardiac, renal, hepatic, or nutritional disorders.
Right, so figuring out the underlying cause usually boils down to identifying or excluding conditions within those 4 big buckets.
Okay, let's go through them one by one, as detailed in the source, and try to link back to those mechanisms we discussed. First up, heart failure.
Right. As we talked about, heart failure means the heart isn't effectively pumping blood forward. This could be because it can't squeeze hard enough, that's systolic dysfunction, or it can't relax and fill properly, that's diastolic dysfunction.
Either way, blood isn't moving forward efficiently.
Exactly. And this leads to blood backing up in the venous circulation, raising venous pressure. Simultaneously, because blood isn't being pumped effectively forward into the arterial system, you get that crucial reduced effective arterial volume.
Triggering the RAAS and everything else.
Yep, triggering the SNS and RAAS activation, which leads to renal vasoconstriction, reduced glomerular filtration rate, and that retention of salt and water by the kidneys. The combination of the venous congestion pushing fluid out and the systemic fluid retention adding more volume forces fluid into the interstitial space, causing the edema.
Okay, so what are the clinical clues that specifically point towards heart failure as the cause of the edema?
The source says you'll usually find evidence of overt cardiac disease. This could be things like cardiac enlargement or ventricular hypertrophy seen on imaging or an ECG. Along with that, you look for the clinical signs and symptoms of heart failure itself. Shortness of breath or dyspnea, especially with exertion or when lying flat. crackling sounds, called rales or crepitations, heard at the lung bases with a stethoscope, distended neck veins indicating elevated jugular venous pressure, and sometimes an enlarged liver, hepatomegaly, due to the venous blood backing up.
And non-invasive tests are key for confirming the diagnosis.
Absolutely. The source mentions electrocardiography, ECG, echocardiography, which is an ultrasound of the heart, invaluable for assessing structure and function, and measuring blood levels of those natriuretic peptides we discussed, BNP or NT-proBNP, which are typically elevated in heart failure.
Looking at Table 4101 in the source material, are there some characteristic lab findings associated with cardiac edema?
Yes. The table highlights a few things. An elevated ratio of blood urea nitrogen, BUN, to creatinine is common, suggesting reduced kidney perfusion relative to filtration. Serum sodium levels are often diminished, particularly in more severe or chronic heart failure, a dilutional effect. And, as expected, those natriuretic peptides, BNP or NT-proBNP, are elevated.
And the physical exam findings listed in that table just reinforce the clinical picture we discussed.
They do. Elevated jugular venous pressure is a key sign. You might hear an extra heart sound, a ventricular gallop sound called an S3. Sometimes the apical pulse, where you feel the heart beating against the chest wall, might be displaced outwards or feel abnormal, dyskinetic. In severe cases, you might see peripheral cyanosis, a bluish tinge to the fingers and toes, along with cool extremities and a small pulse pressure, all indicating poor circulatory output.
And the typical distribution of the edema in heart failure, where does it usually show up?
It's classically found in the dependent portions of the body, the legs, ankles, and feet. And it tends to get worse as the day goes on, accentuated in the evening due to the effects of gravity.
What if the patient is mostly bedridden?
Good point. In patients confined to bed, the edema shifts. Gravity pulls it posteriorly, so it becomes most prominent in the presacral region, the area over the lower back and tailbone.
Okay, that's heart failure. Next major category, according to the source, edema of renal disease. This covers both acute kidney problems like glomerulonephritis and chronic renal failure.
Right. Let's start with acute glomerulonephritis. This is often characterized by a sudden onset and typically associated with hematuria, blood in the urine, proteinuria, protein in the urine, and hypertension, high blood pressure.
Okay, and the edema mechanism here is different from heart failure.
Yes, this is a really key distinction the source makes. In most instances of acute glomerulonephritis, the edema results from primary renal retention of sodium and water. The kidney itself is acutely inflamed or damaged and simply cannot excrete salt and water properly.
So the kidney is the primary problem, not a secondary response.
Exactly. It's holding onto fluid because it's malfunctioning. This is critically different from most forms of heart failure, where the kidney retention is a response to perceived arterial underfilling. And the source emphasizes another difference. In acute glomerulonephritis, cardiac output is often normal or sometimes even increased, unlike the low output typical of systolic heart failure.
Okay, and what about chronic renal failure, or CRF?
Patients with chronic renal failure, meaning long-term loss of kidney function, can also develop edema. And again, it's typically due to this primary renal retention of sodium and water. As kidney function declines over time, the remaining nephrons simply lose the capacity to handle the body's normal salt and water load effectively.
Table 41-1 gives some clinical details for chronic renal failure edema.
Yes. By definition, it's usually a chronic, long-standing issue. Patients may have signs and symptoms of uremia. That's the buildup of toxic waste products that the failing kidneys can no longer clear adequately.
What are some signs of uremia?
Things like decreased appetite, an altered taste sensation, often described as metallic or fishy, altered sleep patterns, difficulty concentrating, sometimes restless leg syndrome or muscle twitching called myoclonus. Shortness of breath can occur, often due to fluid overload or related anemia, but the source suggests it's generally less prominent than in severe heart failure.
And the lab findings are pretty indicative of kidney failure.
Oh, absolutely. Key markers are an elevation of serum creatinine and often cystatin C. These directly reflect reduced kidney filtration function. You'll see protein in the urine, albuminuria, electrolyte imbalances are common, high potassium, hyperkalemia, metabolic acidosis, too much acid in the blood, high phosphate, hyperphosphatemia, often low calcium, hypocalcemia, and usually there's anemia, typically normal-cytic, normal-sized red cells, because the failing kidneys don't produce enough erythropoietin, the hormone needed to stimulate red blood cell production.
And physical exam findings in CRF.
Elevated blood pressure is very common. You might see changes in the back of the eyes related to hypertension, called hypertensive retinopathy. In advanced uremia, there might be a characteristic odor on the breath, a nitrogenous fetor. And in very severe late-stage cases, you might hear a pericardial friction rub, indicating inflammation of the sac around the heart due to uremic toxins.
Okay, that covers renal causes.
Mhm.
The third major category for generalized edema is nephrotic syndrome and other hypoalbuminemic states.
Right, and this takes us squarely back to one of those fundamental mechanisms we discussed earlier, reduced plasma oncotic pressure.
Because of low protein in the blood.
Exactly. The primary alteration, the core problem in nephrotic syndrome, is a massive loss of protein, especially albumin, into the urine. The definition usually requires protein losses of 3.5 grams or more per day.
That's a huge amount of protein loss.
It is. And this inevitably leads to low levels of albumin in the blood, hypoalbuminemia, typically defined as less than 3.0 grams per deciliter.
And with that low albumin, the plasma just doesn't have enough pulling power to keep fluid inside the blood vessels effectively.
Precisely. As the source explains, because of this reduced colloid osmotic pressure, the sodium in water that the body retains often due to a secondary activation of RAAS because the leakage causes perceived underfilling.
Right.
That retained fluid cannot be effectively confined within the vascular compartment. It leaks out easily into the interstitial space.
And that leakage, paradoxically, further reduces the total and the effective arterial blood volume, which then triggers the RAS and those other retention mechanisms even more strongly.
It becomes a real vicious cycle. The low protein causes fluid leakage. The leakage causes perceived underfilling. The underfilling triggers salt and water retention, and that retained fluid just leaks out even more easily, worsening the edema.
What kinds of underlying kidney diseases cause nephrotic syndrome?
It can occur during the course of a variety of kidney diseases. The source mentions certain types of glomerulonephritis, different from the acute type causing primary retention, diabetic glomerulosclerosis, kidney damage from long-standing diabetes, and hypersensitivity reactions affecting the kidneys. Table 41-1 also lists plasma cell dyscrasias, like multiple myeloma, as an associated condition that can sometimes cause nephrotic range proteinuria.
And clinical signs and lab findings from Table 41-1 for nephrotic syndrome.
While it lists childhood diabetes mellitus as a related condition, emphasizing the link. Physical exam might show that characteristic periorbital edema, swelling around the eyes, and often hypertension. The lab findings are really diagnostic. That massive proteinuria, 3.5 gene era, the resulting hypoalbuminemia, 3.0 GDL, often associated hypercholesterolemia. The liver tries to compensate for protein loss by making more lipids, and sometimes microscopic hematuria, blood in the urine.
And the distribution of edema in nephrotic syndrome, is it different from heart failure?
It's typically described as diffuse and symmetric, affecting the whole body because the low oncotic pressure is everywhere. However, it's often most prominent in dependent areas, like the legs. But that periorbital edema, the puffiness around the eyes, is particularly characteristic and often most pronounced first thing in the morning, again, due to the recumbent posture overnight allowing fluid to shift to the face.
Okay. Fourth major generalized cause, hepatic cirrhosis.
Right, cirrhosis of the liver. This one seems to combine several different mechanisms we've talked about.
Yeah, it involves the liver and seems to have elements of both obstruction and impaired protein production.
It does. Cirrhosis involves extensive scarring or fibrosis within the liver. This scarring obstructs the normal flow of blood through the portal vein system, which drains the intestines, spleen, and pancreas.
So blood flow through the liver is blocked.
Increasingly blocked, yes. This leads to hepatic venous outflow obstruction and, consequently, portal hypertension, high pressure in that portal system. This pressure increase causes blood to back up and pool in the splenic circulation, those veins draining the abdominal organs. It also increases the formation of lymph fluid within the liver itself.
So blood is kind of backing up and getting congested within the abdomen.
Exactly. Now, this intrahepatic hypertension combined with other factors common in cirrhosis, like peripheral arterial vasodilation, where blood vessels and the rest of the body relax too much.
Okay.
This combination leads to, yet again, reduced effective arterial blood volume. The body perceives underfilling.
And that activates the kidney's retention mechanisms.
Precisely. It acts as a potent stimulus for renal sodium and water retention, activating the RAS, as shown clearly in Figure 4101b in the source.
And the liver's role in making proteins adds another layer to this.
Absolutely crucial. A severely damaged cirrhotic liver often cannot synthesize enough albumin. This leads to hypoalbuminemia, which, as we've repeatedly discussed, lowers the plasma oncotic pressure, further contributes to the perceived reduction in effective arterial volume and makes it easier for fluid to leak out into the tissues, worsening both ascites and peripheral edema.
And isn't there something about aldosterone clearance, too?
Yes, good point. The source specifically notes that the damaged liver's reduced ability to metabolize and clear hormones from the bloodstream means that circulating levels of aldosterone are often elevated in cirrhosis, sometimes even beyond what the RAAS activation alone would cause. This impaired clearance further promotes sodium retention.
So multiple factors converging: portal hypertension, vasodilation causing underfilling, low albumin, and high aldosterone. It's a perfect storm for fluid accumulation.
It really is.
What does cirrhosis-related edema typically look like? Where does the fluid accumulate?
Well, initially, the excess interstitial fluid often tends to localize preferentially upstream of that congested portal venous system. This means it causes ascites, that accumulation of fluid within the peritoneal cavity, the abdomen, which, again, Chapter 50 discusses in detail.
So ascites often comes first.
Often, yes. Then, in later stages, particularly when the hypoalbuminemia becomes severe, peripheral edema may develop, typically in the legs and ankles.
Okay.
And the source adds an interesting mechanical point. A sizable accumulation of acidic fluid can actually increase the pressure inside the abdomen significantly. This increased intra-abdominal pressure can compress the veins returning blood from the lower extremities, thereby impeding venous return and actually contributing to the accumulation of edema in the legs.
Wow, so the ascites itself can worsen the leg edema.
It can.
What are some of the clinical signs from Table 41-1 that point towards cirrhosis as the cause?
Okay, the table notes that shortness of breath is generally uncommon, unless the ascites is so massive that it pushes up on the diaphragm and restricts breathing. There's often, though not always, a history of significant ethanol abuse, as that's a major cause of cirrhosis. Ascites itself is a very frequent finding.
What about vital signs?
Jugular venous pressure is typically normal or even low, unlike in heart failure, and blood pressure is often lower than you would typically see in patients with renal or cardiac causes of edema.
And you look for other signs of chronic liver disease.
Yes, definitely. You look for one or more additional signs like jaundice, yellowing of the skin and eyes, palmar erythema, redness of the palms, Dupuytren's contracture, thickening of tissue in the palm causing fingers to curl, spider angiomata, small spider-like blood vessels visible on the skin, especially the upper body, gynecomastia, breast enlargement in males, and in more advanced cases, signs of hepatic encephalopathy like asterixis, a flapping tremor of the hands, or other signs of altered mental status.
And the lab findings in cirrhosis.
If the liver failure is severe, you'll see reductions in serum albumin, cholesterol, and other proteins. The liver is responsible for synthesizing, like transferrin and fibrinogen. Liver enzyme levels, like AST and ALT, can be elevated, but the degree depends on the underlying cause and how active or acute the liver injury is. Electrolyte-wise, there's often a tendency towards low potassium, hypokalemia, and respiratory alkalosis. And macrocytosis, meaning larger than normal red blood cells, is quite common, often linked to folate deficiency, especially in the context of alcohol abuse.
Okay, that covers the big four generalized causes: cardiac, renal, nephrotic, hypoalbuminemic, and hepatic. But moving beyond those core categories, the source also emphasizes drug-induced edema as a very common reason for swelling.
Extremely common, and Table 41-2 in the source provides a really quite extensive list of culprit medications.
Yeah, it's surprisingly long.
It is. A large number of widely used drugs can cause edema through various mechanisms. For example, non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen or naproxen, are very common offenders.
How do NSAIDs cause edema?
They tend to inhibit prostaglandin synthesis in the kidneys, which can lead to sodium and water retention and sometimes renal vasoconstriction.
Okay. The list also includes various antihypertensive agents, which seems counterintuitive drugs meant to lower blood pressure causing swelling.
It does seem odd, but certain classes do. The source lists direct arterial and arteriolar vasodilators like hydralazine, clonidine, methyldopa, guanethidine, and minoxidil.
And calcium channel blockers.
Yes, particularly the dihydropyridine type, like nifedipine, amlodipine, felidipine. These are notorious for causing dependent ankle edema. The vasodilation seems to increase capillary hydrostatic pressure, preferentially in the lower extremities.
Okay, what else on the antihypertensive list?
Alpha-adrenergic antagonists are also mentioned.
And drugs for other conditions. I see diabetes drugs listed.
Yes, the thiazolidinediones, or TZDs like pioglitazone and rosiglitazone, can cause significant fluid retention, sometimes worsening heart failure.
Steroid hormones are on there too.
Definitely. Glucocorticoids, like prednisone or hydrocortisone, are well known to cause fluid retention and swelling. Anabolic steroids also, and hormonal therapies like estrogens and progestins.
Any others that stand out?
Cyclosporine, an immunosuppressant, growth hormone, and certain immunotherapies that are increasingly used like interleukin-2, IL-2, and the OKP3 monoclonal antibody. These can sometimes cause a profound capillary leak syndrome with widespread edema.
That's a truly diverse range of medications, and the mechanisms are varied too.
Yes, the source notes the mechanisms involved can include renal vasoconstriction, like NSAs, vasodilation leading to altered capillary pressures, like calcium channel blockers, direct effects augmenting renal sodium reabsorption, like steroid hormones, and even direct capillary damage or increased permeability, like some immunotherapies.
This really raises an important practical question, doesn't it? Yep. Given just how many common drugs are on this list, isn't taking a really detailed medication history, including over-the-counter meds like NSAIDs, absolutely essential when evaluating someone with new or worsening edema?
Oh, absolutely non-negotiable. It should be one of the very first things you ask about. Often the edema resolves simply by stopping or changing the offending medication.
Okay. Finally, under the umbrella of generalized causes, the source discusses edema of nutritional origin.
Right. This is typically linked to severe, prolonged dietary deficiency, especially a lack of protein.
Like in cases of starvation or severe malnutrition.
Correct. A diet grossly deficient in calories, and particularly in protein over an extended period, can lead to profound hypoproteinemia, very low levels of protein, especially albumin in the blood.
And this causes edema directly by reducing that plasma-oncotic pressure, just like we saw in nephrotic syndrome.
Exactly the same mechanism, not enough pull to keep fluid in the vessels.
The source also mentions Beriberi heart disease complicating this.
Yes, interestingly, Beriberi heart disease, which is caused by a severe deficiency of thiamine, vitamin B1, another nutritional problem, can actually worsen this type of edema. The text explains that Beriberi causes multiple peripheral arteriovenous fistulae.
Fistulae? Abnormal connections between small arteries and veins.
Yes, bypassing the normal capillary beds. Blood shunts directly from the arterial to the venous side.
So blood takes a shortcut, bypassing the tissues it's supposed to perfuse.
Essentially, yes. This results in a state of high cardiac output. The heart pumps a lot of volume, but paradoxically, poor effective systemic perfusion and a reduced effective arterial blood volume, as depicted in figure 41 to 1b.
Ah, so the body thinks it's underfilled again, even with high flow.
Exactly. And this perception activates those fluid retention mechanisms, RAAS, etc., enhancing edema formation on top of the edema already caused by the low protein levels.
That's a really unique mechanism, a high output failure state leading to perceived underfilling and fluid retention.
It is quite distinct. And then there's this peculiar phenomenon the source mentions, refeeding edema.
Refeeding edema. That's where someone who has been starving actually develops edema, or their existing edema gets worse when they start eating adequately again. That sounds completely counterintuitive. Getting nourishment causes swelling.
It certainly sounds backwards, doesn't it? And the source offers a couple of proposed reasons. It could be partly due to the sudden increase in sodium intake that comes with resuming a normal diet. The body, maybe still primed for retention, holds on to this sodium along with water. The text also suggests that the increased release of insulin that occurs upon refeeding might play a role. Insulin itself can directly increase sodium reabsorption by the kidney tubules.
I didn't know insulin did that.
It's one of its lesser-known effects. And the source adds that other factors lingering from the starvation state, like maybe underlying hypokalemia, low potassium, or just the general metabolic shift from caloric deficit, might also be involved in this paradoxical refeeding edema response.
So the body's whole physiological system making that drastic shift from starvation mode back to a repletion mode can temporarily trigger this unexpected fluid retention.
It appears to be a complex metabolic adjustment phase.
Okay, so we've now covered the major categories of generalized edema, the swelling that affects the whole body, typically triggered by these systemic problems in the heart, kidneys, liver, nutrition, or due to drugs. But the source also makes sure to detail localized edema swelling that's confined to a specific limb or body part.
Right. And unlike generalized edema, which usually points towards widespread organ dysfunction or systemic issues, localized edema is typically caused by problems affecting fluid drainage or pressures in that specific region only.
What are the common causes of localized edema mentioned in the text?
Well, conditions affecting the veins in a particular limb are a major category. Things like thrombophlebitis, that's a blood clot causing inflammation in a vein, often in the leg.
DVT. Deep vein thrombosis.
Yes, a DVT is a prime example. Also, chronic venous insufficiency due to varicose veins or primary failure of the valves within the veins.
Okay. And in these cases, what's the mechanism?
The source explains it clearly. Blood has trouble draining properly through those obstructed or incompetent veins. This causes pressure to build up upstream of the blockage, or valve failure specifically, in the capillary beds that feed into those affected veins.
Higher pressure in those capillaries.
Yes.
Takes us right back to mechanism number 1 of edema formation we discussed at the start.
Exactly. That increased intracapillary hydrostatic pressure forces an abnormal quantity of fluid out of the capillaries and into the interstitial space, but only in that specific limb or area served by the affected veins, hence localized swelling.
Makes sense. Another major cause listed for localized edema is lymphatic obstruction.
Yes, problems with the lymphatic drainage system in a specific area. This can be caused by various things. Chronic infections involving the lymphatic vessels themselves, called lymphangitis. Surgical removal of regional lymph nodes, which is very common in treatments for cancers like breast cancer or melanoma, disrupting drainage from the corresponding limb. Certain parasitic infections like filariasis, which specifically target and damage lymphatics, leading to conditions like elephantiasis, and also genetic conditions, often called primary lymphedema, where the lymphatic system itself is underdeveloped or abnormal from birth. The source even mentions specific genetic findings, referencing further reading about GJC2 gene mutations causing human lymphedema.
The text notes that edema caused by lymphatic obstruction can be particularly difficult to treat, even intractable. Why is lymphedema often so stubborn?
It's largely due to a combination effect that makes it different from simple venous edema. When lymphatic flow is restricted or blocked, the body's primary system for clearing not just excess interstitial fluid but also leaked proteins is impaired. This does a couple of things. First, it can indirectly increase intracapillary hydrostatic pressure because the interstitial pressure isn't being lowered effectively by lymphatic drainage, which normally helps pull fluid out of capillaries and aids venous return. But more importantly, the failure to clear proteins leads to a significant increase in the protein concentration within the interstitial fluid itself.
Ah, right. And protein accumulating outside the vessels exerts its own oncotic pull, drawing more fluid out and holding it there.
Precisely. So the source explains that this detrimental combination, often increased intracapillary pressure and significantly increased interstitial protein concentration, acts synergistically to severely aggravate fluid retention in that area. It makes the edema particularly resistant to simple measures like elevation that might help purely venous edema. Lymphedema fluid tends to be thick and protein-rich, leading to tissue changes over time, making it feel more firm and less pitting than other types of edema.
So lymphedema isn't just excess water. It's this stagnant, protein-rich fluid that promotes inflammation and fibrosis, making it much harder for the body to reabsorb or mobilize.
That's a very accurate description. The source also lists unilateral paralysis as a cause of localized edema.
Paralysis on one side. How does that cause swelling just on that side?
It's due to the loss of the muscle pump. Normally, muscle contractions in our limbs play a significant role in helping to pump both venous blood and lymphatic fluid back towards the heart.
Okay.
When a limb is paralyzed, that lack of muscle movement significantly reduces the effectiveness of this pump mechanism on the affected side. This impaired venous and lymphatic drainage can lead to unilateral edema in the paralyzed limb.
Interesting. And one more specific obstruction mentioned. Obstruction of the superior vena cava.
Yes, the SVC. This is the large vein that returns deoxygenated blood from the entire upper body, the head, neck, arms, and upper chest, back to the heart. If the SVC becomes obstructed, perhaps by a tumor or a clot,
Pressure builds up behind the blockage.
exactly. Pressure builds up dramatically in the entire venous system, draining those upper body areas. So the resulting edema in this specific case is confined characteristically to the face, neck, and upper extremities, precisely those regions where the venous pressure is elevated, while the lower extremities remain unaffected.
Okay. Are there just a few other specific, somewhat miscellaneous causes of edema listed that don't fall neatly into those generalized versus localized buckets?
Yes. Towards the end of that section on causes, the source mentions a few more specific conditions. Hypothyroidism or myxedema.
Underactive thyroid.
Right. This can cause a type of edema. The text states this is due to the deposition of hyaluronic acid, which is a type of glycosaminoglycan, a complex sugar molecule in the interstitial space. This deposition increases tissue oncotic pressure and holds water.
And interestingly, the source also lists hyperthyroidism over active thyroid, specifically mentioning pretibial myxedema, which can occur in Graves' disease.
Correct, and the text makes a point of noting that the edema in this specific condition, the pretibial mixed edema associated with Graves' disease, is typically non-pitting. That's a key distinguishing feature. The skin often feels thickened and almost waxy.
Okay. What else?
Exogenous hypercortisolism is mentioned. That means having high cortisol levels due to taking medications like high-dose steroids. We saw steroids under drug-induced edema, but it's worth noting again. Pregnancy is listed as a common cause of edema, particularly in the lower extremities, due to hormonal effects and the physical pressure of the growing uterus on pelvic veins.
Makes sense.
And finally, it reiterates the point about administration of estrogens and certain vasodilators, specifically calling out the dihydropyridine calcium channel blockers, like nifedipine again, as common culprits for causing edema, typically ankle swelling.
That is an incredibly comprehensive list. It really drives home just how many different physiological pathways and pathological conditions can ultimately lead to the common endpoint of fluid accumulation in the tissues.
It does. And having that broad understanding of the potential underlying causes is exactly what informs the clinical approach to the patient presenting with edema. The source outlines a very clear, logical sequence of questions and assessments for figuring things out.
And the first, most fundamental branching point in that assessment is determining whether the edema is localized or generalized, right?
Absolutely. That's question number one. If the swelling is clearly confined to one specific area, say one leg or one arm,
you focus your investigation on identifying the local phenomena responsible. Is it a venous problem, like a DVT? Is it lymphatic obstruction? Is it related to paralysis or maybe SVC syndrome if it's the upper body?
Precisely. You target your investigation locally.
But if the edema is generalized, affecting the whole body to some degree, then you need to start thinking about those systemic causes we spent so much time on.
Right. And the source provides a clear algorithm for approaching generalized edema. The first step, according to the text, is to determine if there is serious hypoalbuminemia. Specifically, is the serum albumin level less than 3.0 GDL?
Okay, check the albumin first. If it is that low, what's the next step?
If yes, the text says you immediately use the patient's history, their physical examination findings, a urinalysis to check for protein loss, and other relevant laboratory data to specifically evaluate for the main causes of severe low albumin associated with widespread edema, namely hepatic cirrhosis, severe malnutrition, or the nephrotic syndrome.
So low albumin points you directly towards those three possibilities. What if the albumin level is not seriously low? Say it's above 3.0 GDL.
Okay. If significant hypoalbuminemia is not present, the next critical question to ascertain is whether there is evidence of heart failure that's severe enough to be causing generalized edema.
So you look for those clinical signs we discussed earlier, the shortness of breath, the elevated neck veins, the lung crackles, the S3 gallop, maybe cardiac enlargement on exam or imaging.
Exactly. You assess for clinical evidence of heart failure.
And what if neither significant hypoalbumin nor clear signs of heart failure seem to be the primary driver?
Then the final crucial step in this initial assessment pathway, as highlighted by the source, is to determine the patient's kidney function by assessing their urine output. Is the patient producing an adequate amount of urine? Or is there significant oliguria, meaning very low urine output, or even anuria, which is essentially no urine output at all?
Right. The
text explicitly mentions that these abnormalities, oliguria and anuria, are discussed in more detail in other chapters, specifically referencing chaps 52, 310, and 311, emphasizing just how important assessing urine output is. Significant reduction in urine output strongly points towards a primary kidney problem, acute or chronic renal failure, as the likely cause of the fluid retention.
Wow. That structured approach first, localized versus generalized. Then, if generalized, check albumin. If albumin's okay, check for heart failure. If heart failure isn't obvious, check kidney output that provides a really logical and efficient framework for a clinician to navigate the vast number of possibilities we've discussed and narrow down the likely cause.
It does. It's about using the key physical signs and some basic laboratory data like serum albumin and urinalysis, along with assessment of urine output, to guide the investigation systematically toward the most probable underlying mechanism and disease process. It's the clinical application of all the physiology.
It's taking all that complex pathophysiology we've unpacked and applying it in a practical diagnostic sequence.
Precisely. Now, shifting gears just slightly, but still within the scope of Chapter 41 in our source material, there's another important physical sign discussed that's often seen alongside edema or cyanosis in certain specific underlying conditions. That's clubbing of the digits.
Clubbing, right. What exactly is clubbing? I know the term, but what are the specific changes?
The source defines it carefully as a selective bulbous enlargement of the distal segments of the fingers and toes, so the very ends. It's more than just having chubby fingers. The text describes specific changes. There's a proliferation of connective tissue, particularly on the dorsal surface, the top side near the nail, and importantly, an increased sponginess of the soft tissues right at the base of the nail bed itself.
So the fingertips get wider and rounder, and the area where the nail emerges feels kind of soft or boggy when you press on it.
That's a good description, yes. That loss of the normal angle between the nail and the nail bed and the sponginess are key features. Clubbing can sometimes run in families, hereditary, or happen for no known reason, idiopathic, but the form we're most interested in clinically is acquired clubbing because it serves as a physical sign pointing towards some other underlying medical condition.
Okay, and the source lists quite a wide variety of disorders that are associated with acquired clubbing.
It's a surprisingly long and diverse list, which really underscores why this sign, although perhaps subtle sometimes, is so important for clinicians to look for. It's commonly seen, for instance, with cyanotic congenital heart disease.
Those are heart defects present from birth that cause low oxygen levels in the blood, leading to a bluish color. Cyanosis, often because blood is shunting away from the lungs.
Exactly. And in many of those conditions, cyanosis and clubbing are frequently found together.
Okay. What else causes clubbing?
Infective endocarditis, which is an infection of the heart valves, can also cause it. And then there's a large category of pulmonary or lung conditions associated with clubbing.
Which lung conditions are most strongly linked to clubbing?
The source lists quite a few significant ones. Primary and metastatic lung cancer are major causes to consider. Chronic lung infections or inflammatory conditions like bronchiectasis, where airways become damaged and widened. Lung abscesses and cystic fibrosis. Certain interstitial lung diseases like asbestosis and sometimes sarcoidosis, even tuberculosis. And mesothelioma, that cancer often linked to asbestos exposure, affecting the lining of the lungs or abdomen.
Wow, that's a substantial list of serious lung problems.
Yeah.
The source says it's also linked to some gastrointestinal diseases.
Yes, certain GI diseases are associated with clubbing, including inflammatory bowel disease conditions like Crohn's disease or ulcerative colitis, and also hepatic cirrhosis, bringing back one of the causes we discussed for generalized edema.
Interesting overlap there.
And finally, the source mentions it can occasionally be occupational, giving the specific example of jackhammer operators, possibly due to chronic vibration.
That's a really broad range of conditions. Heart, lungs, GI system, liver, even occupational exposure. Really makes you wonder what the common link could be.
It does. And the source notes that in certain conditions, specifically mentioning primary or metastatic lung cancer, mesothelioma, bronchiectasis, and hepatic cirrhosis clubbing may be associated with a related but distinct condition called hypertrophic osteoarthropathy, or HOA.
Hypertrophic osteoarthropathy. What exactly is that?
HOA involves the superiosteal formation of new bone. That means new bone is actually developing along the outer layer, the periosteum, of the long bones, particularly in the distal parts of the extremities, like the forearms and lower legs.
And this causes symptoms.
Oh, yes. It typically causes pain, sometimes quite severe, and symmetric arthritis-like changes, swelling, tenderness, warmth in the joints, particularly affecting the shoulders, knees, ankles, wrists, and elbows. It can be quite debilitating.
How is HOA diagnosed?
The diagnosis can usually be confirmed by seeing the characteristic periosteal new bone formation on a standard bone radiograph, X-ray, or sometimes with magnetic resonance imaging, MRI.
Okay. What about the mechanism behind clubbing itself? Does the source shed light on why fingertips enlarge like that?
Well, the text explicitly states that the mechanism of clubbing is actually unclear, which is quite fascinating given how long this physical sign has been recognized by physicians.
Still a bit of a medical mystery.
To some extent, yes. However, the source mentions the prevailing theories. It appears to be secondary to humoral substances, meaning chemical messengers circulating in the blood that cause dilation of the blood vessels in the distal digits.
Okay.
Additionally, the source suggests that growth factors potentially released from platelet precursors or fragments that get trapped in the digital circulation might play a role in stimulating that connective tissue proliferation we see.
So the idea is that a problem somewhere else in the body, like the lungs or liver, releases certain factors into the bloodstream. And these circulating factors then specifically target the fingertips and toes, causing blood vessels to widen and connective tissue to grow.
That seems to be the leading hypothesis. What's really fascinating here is trying to understand how a systemic issue, maybe hypoxia or inflammation originating far away, could trigger such a specific, localized tissue growth response only in the very ends of the digits. It's a clear physical manifestation of a distant problem, likely mediated by something carried in the blood.
And the source mentions that clubbing can sometimes be reversible.
Yes, it can be. The text gives the specific example of clubbing sometimes improving or even resolving following lung transplantation for patients with cystic fibrosis. If you can successfully treat the underlying cause, the clubbing may regress over time.
Now, going back to that connection with cyanosis that was mentioned right at the start of Chapter 41 in the source material, it seems the presence or absence of clubbing provides important differentiating information when cyanosis is present.
Yes, this is a key clinical distinction highlighted in the text. The combination of cyanosis, bluish discoloration due to low oxygen, and clubbing is frequent in patients with certain types of congenital heart disease, specifically those causing right-to-left shunting where blood bypasses the lungs. It's also seen occasionally in specific pulmonary diseases like a chronic lung abscess or pulmonary arteriovenous fistulae, abnormal direct connections between arteries and veins within the lungs.
Okay, so cyanosis plus clubbing points towards those specific types of chronic heart or lung issues. What about cyanosis without clubbing?
That's the contrast the source draws. Peripheral cyanosis, like having bluish cold hands and feet due to poor circulation or cold exposure, is not associated with clubbing. Similarly, acutely developing central cyanosis, like someone suddenly becoming blue due to a severe, rapid onset lung problem, like massive pulmonary embolism or acute respiratory distress syndrome, is also not typically associated with club digits because there simply hasn't been enough time for the clubbing changes to develop.
Okay, so this raises an important question. What does the presence of clubbing in someone who is cyanotic immediately tell you about the likely nature of their underlying problem?
It strongly suggests that the underlying condition causing the cyanosis is likely chronic, having been present long enough for those slow structural changes of clubbing to occur. Or it points towards specific types of vascular abnormalities like shunts or fistulae that are known to be associated with both cyanosis and clubbing. It helps differentiate acute from chronic causes and points towards certain pathologies.
So clubbing really adds a crucial layer of diagnostic information when you encounter a patient with cyanosis. It helps significantly narrow down the possibilities.
It's a vital clinical clue, absolutely.
Okay, moving now to the third physical sign covered in our source material, let's briefly touch upon heart murmurs. This information comes from the excerpt provided from Chapter 42. While it's not as extensive as the deep dive into edema, it lays the essential groundwork for understanding these important heart sounds.
Right. Heart murmurs are defined quite simply in the text as audible vibrations. When a clinician listens to the heart using a stethoscope, murmurs are essentially extra sounds beyond the normal lub-dub that they might hear.
And what causes these extra sounds, these vibrations?
According to the source, they are caused by increased turbulence of blood flow within the heart chambers or the major blood vessels connected to the heart, like the aorta and pulmonary artery. Normally, blood flow through the heart should be smooth and relatively silent, what we call laminar flow. But under certain conditions, that flow becomes chaotic and turbulent, and this turbulence creates vibrations that we can hear as murmurs.
Okay, turbulent flow. The source lists specific types of flow abnormalities that typically cause this turbulence.
Yes, it outlines three main categories of conditions that make blood flow turbulent. First, simply accelerated blood flow through either normal or abnormal orifices. If the heart is pumping much faster or harder than usual, like during exercise, fever, or hyperthyroidism, even normally functioning valves might generate some turbulence and a flow murmur.
Okay, just fast flow. What's the second category?
Second, flow through a narrowed or irregular orifice into a dilated vessel or chamber. Think of blood being forced through a stenotic or narrowed valve. It squirts through that tight opening like water through a pinched hose nozzle, and then enters a wider chamber or vessel beyond the valve where it swirls around turbulently. This is typical of valve stenosis, like aortic stenosis or mitral stenosis.
Okay, flow through a narrowing. And the third category?
Third is backward flow, also known as regurgitation. This occurs when blood leaks backwards through an incompetent or leaky valve that doesn't close properly.
It's like mitral regurgitation or aortic regurgitation.
Exactly. Or backward flow can also occur through abnormal connections between heart chambers or major vessels, like a ventricular septal defect, VSD, which is a hole between the two ventricles, or a patent ductus arteriosus, PDA, which is a persistent connection between the aorta and pulmonary artery that normally closes shortly after birth.
So essentially anything that makes blood flow rough instead of smooth, whether it's going too fast, being squeezed through a tight spot, or flowing backwards where it shouldn't, can create turbulence and a murmur.
That sums it up nicely. Now, the source emphasizes the absolute critical importance of timing when assessing a heart murmur. Murmurs are traditionally classified based on when they occur within the cardiac cycle. And getting the timing right is the very first, most fundamental step in identifying what a murmur might represent.
And we time them relative to the normal heart sounds, S1 and S2, the lub and the dub.
Precisely. S1, the first heart sound, lub, is caused by the closing of the mitral and tricuspid valves, the valves between the atria and ventricles. This marks the beginning of ventricular contraction, which is called systole. S2, the second heart sound, dub, is caused by the closing of the aortic and pulmonic valves, the valves leading out of the ventricles. This marks the end of systole and the beginning of ventricular relaxation called diastole.
Okay, so a systolic murmur is one that happens during systole, between S1 and S2.
Correct. The source defines systolic murmurs carefully. They begin either with or after S1, and they terminate at or before the component of S2, either the aortic component, A2, or the pulmonic component, P2, that corresponds to their side of origin. Left side for A2, right side for P2.
And diastolic murmurs, logically, happen during diastole, between S2 and the next S1.
Exactly. Diastolic murmurs begin either with or after the associated component of S2, A2, or P2, and end at or before the subsequent S1.
The source also mentioned continuous murmurs. What are those?
Continuous murmurs aren't confined to just systole or just diastole. Instead, they start somewhere in systole, proceed right through S2 without stopping, and continue into all or at least part of the following diastole. The classic example, as mentioned before, is the murmur heard with a patent ductus arteriosus.
Now, telling S1 from S2 is usually straightforward, but the text notes it can be tricky sometimes, especially if the heart rate is very fast, like an tachyarrhythmia. It offers a practical tip for distinguishing them in difficult cases.
Yes, a very useful bedside tip. It suggests simultaneous palpation of the carotid artery upstroke in the neck. The carotid pulse, the wave of blood ejected from the left ventricle into the aorta, occurs very shortly after S1, which is the sound of the mitral valve closing right before ejection.
Okay.
So if you're feeling the carotid pulse, the heart sound you just heard, or are hearing immediately preceding that pulse, is almost certainly S1. This helps you orient yourself in the cardiac cycle even when the sounds are running together quickly.
That's a really practical skill for auscultation. The source also briefly mentions the importance of murmur duration and character, although it doesn't go into great detail in this excerpt.
Yes. It notes that the duration of a murmur depends on how long the pressure difference causing the turbulent flow exists between the two chambers or vessels involved during that phase of the cardiac cycle. And character or quality things like whether the murmur sounds harsh, blowing, rumbling, musical, high-pitched, low-pitched. These are also very important descriptive features that experienced clinicians use to help identify the specific cause of the murmur, although they weren't the focus of this particular source excerpt.
Finally, the source highlights the significant clinical value of accurately identifying heart murmurs right there at the bedside, using just a stethoscope and clinical skills.
Absolutely. It emphasizes that accurate bedside identification is crucial foundational information. Hearing a murmur and correctly timing and characterizing it helps clinicians make informed decisions about whether further non-invasive testing, like an echocardiogram, is truly necessary. It guides decisions about the potential need for referral to a cardiovascular specialist.
And it also allows for important initial patient discussions.
Yes. Based on the likely significance of the murmur heard, preliminary conversations can be initiated with the patient regarding important issues like, do they need antibiotic prophylaxis before certain dental or surgical procedures to prevent endocarditis? This depends heavily on the specific underlying valve issue. Is there potential need for rheumatic fever prophylaxis in some specific cases? Do they need to restrict certain types of strenuous physical activity? And importantly, is there potential role for screening family members if the suspected condition might be inherited?
So something as seemingly simple as carefully listening to the heart sounds and identifying a murmur can provide incredibly vital clues that initiate a whole diagnostic workup and patient management pathway.
It really is a fundamental part of a thorough physical examination, and the information gained has significant implications for patient care, guiding everything from further testing to preventative strategies and counseling.
We have certainly covered a tremendous amount of ground today. We took a truly deep dive into the complex, interconnected world of edema, starting with how fluid balance is normally maintained at the capillary level through hydrostatic and oncotic pressures and lymphatic drainage. Then exploring how disruption to any of those factors, increased pressure, low protein, leaky capillaries, or blocked lymphatics, causes fluid to accumulate in the interstitial space.
And we spent significant time unpacking those powerful systemic responses, particularly the renin-angiotensin-aldosterone system, along with the SNS, AVP, and endothelin, all typically triggered by that crucial concept of perceived arterial underfilling.
Right, how these retention mechanisms drive fluid retention, often overwhelming the body's natural but apparently less potent diuretic system, the natriuretic peptides.
We then meticulously explored the major causes of generalized edema heart failure, various forms of kidney disease, including nephrotic syndrome, hepatic cirrhosis, a wide range of drugs, and even nutritional deficiencies, trying to link the typical clinical signs, lab findings, and patterns of edema distribution back to those underlying physiological mechanisms we discussed.
We also made sure to cover the causes of localized edema, like venous thrombosis or lymphatic obstruction, and touched on other specific types like myxedema associated with thyroid dysfunction.
And shifting slightly, we looked at how other related physical signs, like clubbing of the digits, can serve as vital clues pointing towards a diverse range of underlying conditions, from lung cancers and chronic infections to congenital heart disease and liver cirrhosis. And importantly, how the presence or absence of clubbing helps differentiate potential causes when seen alongside cyanosis.
And finally, we briefly touched on the foundational principles of understanding heart murmurs, those audible vibrations caused by turbulent blood flow, and emphasize how accurate timing within the cardiac cycle is the critical first step in identifying their potential significance and guiding further clinical evaluation and management.
It's abundantly clear from this deep dive, isn't it, that understanding these common physical signs isn't just about memorizing lists of causes. It's truly about seeing the connections, how issues in fluid dynamics, hormonal signaling, blood flow, or even tissue structure in one part of the body can manifest visibly or audibly elsewhere. It really underscores the incredible interconnectedness of human physiology.
Absolutely. This journey towards mastering this information, as laid out in the source, really shows how vital it is for clinicians and anyone interested in understanding the body to look beyond the surface symptom to the underlying physiological disruption. Consider this final thought. How does having this level of detailed understanding of mechanisms like precisely how angiotensin II affects reabsorption in the peritubular capillaries, or understanding why lymphatic edema is so protein-rich and intractable, empower clinicians to not just identify a problem like edema, but to truly understand why a specific treatment, like blocking the RAS or using compression therapy for lymphedema, might actually be effective? What does this deep dive tell us about the elegance and sometimes the frustrating complexity of the body's own intricate attempts to maintain balance, even when those attempts go awry?